Thank you for joining us today. Welcome, everyone. So I have a few housekeeping notes before we get started. All lines will be on mute. You will notice at the top of your screen there is an emoji icon. Feel free to use that to give a thumbs up if something resonates with you. Beside that is the Q&A feature. Please put your questions there and they will be answered after the presentation. So let's practice here for a second. If you've located the Q&A box, go ahead and hit the emoji icon and give me a thumbs up. Great. Now, as a reminder, this webinar is being recorded and attendees will be able to access it later. I will send you a link with that information once it is ready. The webinar today is being presented by Archway Health. The content and financial support of this webinar is provided by Archway Health. RPA approves this webinar. However, RPA does not endorse this webinar, nor endorse or promote any specific commercial entities or products. Again, thank you for joining us. And now I'd like to turn it over to your presenters today.
Thank you very much, Desiree, and thank you all for joining our webinar. My name is Sam Tai, and I'm a director of the Policy and Solutions Management team at Archway Health. I'm joined today by my colleague, Keely McMillan, who's a Senior Vice President of the Policy and Solutions Management team here at Archway. And we're excited to be speaking with you all today. We'll start with a brief overview of our company and then jump right into talking about kidney care choices. We plan to cover today how you can leverage data to achieve success in the program, options for protecting your downside risk, and then we'll cover some additional considerations for participation in the program. And we should have time at the end of the webinar today to do some question and answers. So as Desiree mentioned, please feel free to submit questions as we go using the question mark icon, and we'll get to it hopefully at the end. So just a little bit about Archway Health to fill you in on who we are. Archway is a value-based care solutions company, and we're really committed to helping providers be successful in value-based care models. We are made up of a diverse team of healthcare policy experts. Myself and Keely fit into that team. We also have data scientists and actuaries. For those of you that are familiar, Archway is a qualified entity with Medicare. We also have insurance and finance experts, and then also some product developers as well. Archway has participated in almost all of Medicare's value-based care programs. Our company was initially founded as a convener in the BPCI Classic program. That's bundled payments for care improvement, for those of you that might not be familiar. Currently, we're a convener in the BPCI Advanced model, and we also provide a combination of analytic and risk protection tools in oncology care, in the oncology care model, in comprehensive joint replacement, and in both the NextGen and MSSP ACO programs. We really sort of nerd out with Medicare VPC. As we've evolved as a company and continued to look for new ways to help providers be successful in these models, we've developed some innovative ways to protect downside risk. And that's why we've partnered with an A-rated insurance carrier. Archway has an MGU relationship with this carrier. So we do the underwriting and the pricing, and the insurance carrier has the paper. And we found that we're able to provide really flexible solutions to providers, which we're really very proud of. So now that you know a little bit about Archway, I want to pause and do a couple questions to learn a little bit more about the attendees we have on the webinar today. So the first question is, what is your organization's experience with value-based care? Feel free to pick the answer that makes the most sense for your organization. So are you in the ESCO model? Are you in ACO? Maybe another program, or maybe you're brand new to value-based care. Just wait another second for answers to roll in. Okay, Steve, I think we can share the responses. Oh, not sure if participants can see those responses, but what I saw in the results is that about a third of the group has participated in the ESCO model. About a third of the group has never participated in a value-based care program before, and then some sort of spread out in ACOs and other programs. And that's great. That's really consistent with what we see when we engage with providers across the country. We're covering a range of topics today, and so I think there's going to be some interesting content for the quote newbies, and then also for the more sophisticated organizations. One more poll question for you all, and then I promise we'll get to the good stuff. Since the topic of the webinar is Medicare's kidney care choices, we'd like to know, is your organization planning to participate in kidney care choices? Okay, answers are still sort of trickling in, but it's really interesting to see that more than half of participants, almost 60%, are planning to participate in CKCC in April. We have a couple people planning to participate in KCF, some that might be interested in participating in cohort 2, and then a handful of people that don't know. That's great. We're excited to see a lot of folks that are getting ready to start the program in a couple months, and we really hope that the material we covered today is going to help you feel a little more ready. So we do have sort of a range of participants on the webinar today, some that are getting ready to get started on the program, some that are relatively new. So I do want to start with a high-level overview of the program. I'll move through it pretty quickly for those of you that are already familiar. To be clear, today we're here to talk about CMMI's new voluntary model, Kidney Care Choices. This is the successor to Comprehensive ESRD Choices model. You may know it as the ESCO program. We are not here to talk about the mandatory ESRD treatment choices, the ETC model that's also beginning in 2021. While we're not focusing on ETC today, it's certainly relevant because it underscores the focus that Medicare is placing on kidney disease in their shift from fee-for-service to value-based care. And then for the handful of people today that are sort of new to kidney care choices based on the poll, I do want to let you know that if you want to learn a little bit more about the basics of KCC or ETC, you can look at RPA's webinar from the fall called Insights into the Kidney Payment Model, What Nephrologists Need to Know. So Kidney Care Choices is actually an umbrella term with two models within it. Both models target Medicare fee-for-service beneficiaries, and it targets patients with chronic kidney disease, stage 4 or stage 5, end-stage renal disease, and patients with successful kidney transplants. Right off the bat here, we see sort of an evolution from the ESCO model in that the scope of these programs has been expanded to patients with CKD. On the left side here of this diagram, we see KCF, Kidney Care First. This model is designed for nephrology practices to participate as a practice is the practice is the participant, excuse me. There are some new payment mechanisms in KCF I want to review with you. Nephrologists will receive upfront quarterly capitated payment for their Medicare CKD stage 4 and stage 5 patients, and this will replace the fee-for-service revenue that they currently earn for evaluation and management and care management services. Nephrologists will continue to receive their monthly capitated payment for their ESRD patients, but there will be an adjustment with a home dialysis true-up, which is designed to incentivize more home dialysis use. There will also be a kidney transplant bonus, which is a $15,000 bonus that will be paid out in 3 installments over 3 years as long as a transplant remains successful. And lastly is the performance-based adjustment component to KCF, which is that a nephrologist's professional fees, those capitated payments that I just talked about, will be adjusted up or down based on their performance on quality gateways and utilization measures. On the right side of this graphic is Comprehensive Kidney Care Contracting, or CKCC, and that's actually going to be the focus of today's webinar. We are really going to hone in on CKCC. Participants in this part of the program are called Kidney Contracting Entities, or KCEs. This is going to be a newly formed organization that's comprised of at least one nephrology practice, but it could be multiple practices, and at least one transplant provider. The entity could also include other types of providers like dialysis organizations, although it doesn't have to. I'll mention a KCE is really not all that different from an ACO for those that are familiar with accountable care organizations. The first three payment mechanisms in CKCC are the same as KCF. So there are quarterly capitated payments for CKD 4 and 5 beneficiaries. There's that adjusted AMCP to incentivize home dialysis, and there's a kidney transplant bonus. The key difference in CKCC compared to KCF, though, is that instead of the performance-based adjustment on professional fees, the KCE can earn shared savings or may be responsible for shared losses. So the KCE's total cost of care, all Part A and Part B expenditures for beneficiaries aligned to the entity, will be compared to a prospective benchmark. If total expenditures come in below that benchmark, the KCE gets to keep some of those savings. And if the expenditures come in above that benchmark, then they'll be responsible for paying back some of those losses to Medicare. You can see here down below, there are 4 risk track options ranging. On the left side, you have graduated level 1, which is upside only. You get to keep 40% of the savings and there's no downside risk. And it ranges all the way up to the global track, which is 100% upside and downside risk. I will note that if you start in graduated level 1 with upside only, you will have to progress over time and take on more downside risk. What I just went over is a super high level overview of the program. There are lots of nuts and bolts and certain mechanics that we didn't go into and we're not going to go into today. But for those of you that are interested in that sort of stuff, we can certainly sort of connect with you after this webinar or provide some additional resources. Here's a quick summary of the program timeline. So there was an application window about a year ago, back in January of 2020, for participants to submit a non-binding application to one or both of the KCC models, so to KCF and or CKCC. Applicants have been receiving more program information over the course of the past year. They started an implementation period in the fall, and Medicare has begun to provide some historical claims files to these applicants. We call this group Cohort 1. And this group has to make their decision to participate in the program this coming March. They'll have to sign a participation agreement. And if they do decide to move forward, their performance year will begin on April 1st of this year. Since we saw in the poll, a lot of people on the webinar today are in Cohort 1. I hope that it's not a surprise to you that you have a pretty big decision to make in March, and we're getting ready to wish you luck in the program. I'll mention that the program was supposed to start on January 1st of this year, but it was delayed by a quarter because of the COVID pandemic. And excitedly, it's exciting to announce that Medicare has said there will be a second open window period for new participants to join for a January 1, 2022 start date. We refer to this group as Cohort 2. Now, Medicare hasn't explicitly stated when this application window is going to be, but based on what we know about how Medicare works, we expect that application window to be this spring, in spring of 2021, for a January 1, 2022 start date. And whether you start the program this year or next year, the program is slated to go through 2025. Now that we've covered some of the basics of the program, let's talk about why a provider might participate really quickly. As I mentioned, this program is designed to build upon lessons learned in the ESCO model. In CKCC, there's certainly a focus on reducing the total cost of care. The hope is that this can be achieved through better care coordination. For patients with late-stage kidney disease, there's a focus on delaying the transition to end-stage renal disease. This is a stated goal of Medicare. And then when a patient does transition to end-stage renal disease and needs to get started on dialysis, the goal is to have better non-emergent starts on dialysis, and of course, to have more home dialysis. We've already talked about the idea of the kidney transplant bonus, which is certainly designed to incentivize more successful transplants. And then lastly, on the CMS sort of side of things, in line with their goal of having 100% of providers in downside risk by 2025, this program offers different financial risk options for nephrologists. Some other reasons to participate in this program, the priorities. So other reasons why you might participate. We spend a lot of time talking about the dollars and cents here and sort of get caught up in the financials, but the key goal of a lot of these value-based care models, all of them really, is to improve outcomes for patients. So I don't want to lose sight on that important point, that this is designed to make patient care better. I'll also mention that by applying to this program, you can get access to valuable data that you wouldn't otherwise get. You get claims data for all of your aligned patients, not just your practice's claims data. So if one of your aligned beneficiaries is hospitalized or goes to a skilled nursing facility, you can get access to that information. All of the new payment mechanisms that we've reviewed here are opportunities to achieve additional revenue compared to traditional fee-for-service. I'll also mention that most of the tracks here in the KCC model do count as an advanced alternative payment model. So participation is likely to allow you to qualify for a macro bonus and for MIPS exemption. This is particularly relevant in light of the recent congressional act, which froze the volume thresholds, you may have heard, so that the requirements to qualify for the macro bonus have been frozen over the next 2 years. This is certainly a big benefit to providers. And then lastly, we know that value-based care is coming. More mandatory models are being rolled out, and we see this as a really great way to gain experience with VBC. So now we're going to transition to the next section of the webinar. We've sort of laid the groundwork and set the stage. And the next section is leveraging data to achieve success. And we're going to start with a quick poll. The question is, which key lever is your organization's top priority for improvement in this program? So we've talked about goals for Medicare, increasing kidney transplant, increasing home dialysis, delaying the progression to CKD, and reducing hospitalizations. Which is your organization's top priority? So answers are still coming in, but it looks like increasing home dialysis, wow, is 64%. It's changing a little bit, 60%, wow. And then another third of participants are really interested in focusing on managing comorbidities. That's great. In this next section, we're going to talk a little bit about how data can sort of help you check to see if those priorities are sort of in line with what you should be thinking about. And I think that they probably are. So on a prior slide, I just mentioned that access to data is a key benefit to participating in this program. We're going to review a few examples of how you can use data insights to achieve success in KCC. I want to note that many of the data insights we're going to review today have been simulated based on the data that providers will get to receive if they're in the program, but we have also supplemented it with Archway's own data sources. So I want to be transparent about that. In this section, we're going to talk about forecasting the impact of new payment mechanisms, identify savings and care improvement opportunities, and then preparing for changes to your aligned beneficiaries. So first up is forecasting the impact of those new payment mechanisms that we just talked about. And we're going to start with QCP. So as I mentioned, nephrologists will have their evaluation and management fee-for-service revenue replaced with an upfront quarterly capitated payment for patients with CKD 4 and 5. Comparing historic fee-for-service revenue to your expected QCP payment is an important exercise for budgeting purposes. So in this example, we see on average, a practice receives about $50 in fee-for-service reimbursement per beneficiary per quarter. Their expected capitated payment rate under CKCC looks like it's going to be about $144 per beneficiary per quarter. That's a pretty significant increase. If you multiply that out across all patients across the whole year, that's going to be an annual change of over $300,000. Knowing this number will be key to leveraging those payments. You may use these funds to hire a care coordinator team or invest in other infrastructure to try and better manage this population. So having a sense of this number going into the program is certainly helpful. Next is the AMCP. So if you looked into CKCC last year, you may remember that Medicare proposed to peg all monthly capitated payments at the 2 to 3 visit rate, regardless of how many times a nephrologist saw a end-stage renal disease patient. Now, in response to stakeholder feedback, Medicare scrapped that idea, and they're going to continue to pay the monthly capitated payment as they do today to nephrologists. There is going to be an adjustment to the MCP, however, which is that a home dialysis true-up amount will be paid at reconciliation to incentivize more home dialysis use. It's helpful, certainly, to understand how your home dialysis use compares to other providers in your region. I saw in the poll that a lot of folks are, very interested in focusing on home dialysis. I wonder how many folks have a good sense of how they compare to sort of regional averages. So on the right-hand side of this slide, we can see an example region in the United States, and the top pie chart shows the home dialysis rate is 9% in this region. Down below, the pie chart shows an example KCE that has a home dialysis rate of 11%. Now, this KCE happens to be beating the average, which is great. It's helpful to know that. But based on what we know and the focus that's being put on home dialysis, there's likely room for improvement even beyond the 11%. And so this provides some insight. On top of that, we also want to be able to quantify the home dialysis true-up that a KCE is going to receive. This is similar to our conversation about the QCP. If you're going to be receiving additional funds at reconciliation, it's really helpful to be able to know that and quantify that and plan accordingly. So in the table on the bottom part of this slide, you can see that there were 201 patients that received home dialysis during a year, and that would translate to a home dialysis bonus of about $46,000. That's $35 for each of the 1,300 or so claims that happened during the year. So we just discussed two of the new payment mechanisms in this model. In CKCC, the payment mechanism that's going to have the biggest impact is the shared savings, shared losses piece. So we've talked about how total cost of care reducing the total cost of care is a main goal of this program, and reducing unnecessary utilization is key to earning shared savings. The point of this next sort of series of slides is to show you that looking at your historical data can help you answer important questions about your KCE. On the right-hand side here, we have an example KCE with some high-level statistics. So there's 823 CKD beneficiaries, 967 ESRD beneficiaries, and a total program size of about $97 million. Program size is a term that we use for the total Medicare Part A and Part B spend for your population. It's essentially the number that's going to be compared to your benchmark at reconciliation. Down below, we have a breakdown of the total spend. You can see 33% for dialysis, 25% for hospitalizations. That orange chunk of the pie is about 10% for comorbidity care. So we see this breakdown of spend, but how do you start to quantify your room for improvement and then identify specific areas where you can, for lack of a better term, trim the fat, reduce unnecessary spend? So for that, we're going to look on the next slide, and we have the same example KCE with the $97 million program size. In this graphic, it's broken out to show, one circle is the CKD program size, and the second circle is end-stage renal disease patients. In order to identify achievable savings opportunity, we want to compare your organization's historic experience to the experience of top performers in your region. We know that it's unreasonable to completely eliminate all hospitalizations. That's not going to happen. But you can work to lower your hospitalization rate so that it's closer to that of top performing practices. That's something that can potentially be achievable. So we define top performers as those that are efficient from a total spend perspective, but they also maintain good quality. And we use the average of the top 25% on a regional basis. We use the 9 US Census regions. So within a handful of states, we look at the top 25% of performers. When we compare the total spend of our example KCE on the left here to the total spend of top performers in their region, we can identify savings opportunity. And in this slide, it's depicted in the green sections. So the green section shows room for improvement compared to top peers. And for CKD, it's about $3.8 million. And for ESRD, it's about $9 million. In total, that's $12 million of savings opportunity. And to say it another way, if this KCE were able to improve their performance to that of the most efficient providers, they would lower their total spend by about $12 million. So it's important to note, I'll make this sidebar right now, that when we compare nephrology practices or KCEs, the data has to be risk adjusted and standardized to account for, varying patient acuity or geographic differences in spend, like area wage. You have to do these adjustments to make it an apples to apples comparison. And so all of the data that we're showing you today has been risk adjusted and standardized. So now that we know that there's meaningful savings opportunity for this KCE, that green $12 million, we need to go a layer deeper to learn where the addressable spend is occurring. So on the right-hand side of the slide now, we see the categories that make up the $12 million of savings opportunity. The total bar at the bottom of this chart lines up with the 12 million we were just talking about. And for both CKD and ESRD populations, acute hospitalizations make up the bulk of that addressable savings opportunity. It's $5.2 million. We can also see that long-term care and skilled nursing facility utilization are significant drivers as well. But for this example, we're going to focus in on hospitalizations. We can zoom in even further into this hospitalization category to learn what the most common and what the most costly reasons for admission are. In this example, diseases of the circulatory system is really the biggest category. For simplicity's sake, let's sort of focus in on the ESRD row within the circulatory system box here. And we can see that there were 328 ESRD patients that had a hospitalization for a circulatory system disease or disorder during a proxy performance year. That's about 28% of the ESRD population. And the total spend on circulatory system hospitalizations is $7.7 million. That works out to be about $646 per beneficiary per month. Okay, I have one final drill down in this sort of journey I'm taking you on, and that is, circulatory systems is still a pretty broad category. So if we zoom in, we can look to see that heart failure and shock is the most common and most costly DRG within this hospitalization category. Not only is it the most common and most costly, but we also see the biggest variance compared to top performers in the region. So the small red line here shows the example KCE's risk-adjusted heart failure admission rate and their per beneficiary per month spend. The little green line to the left of it in this box shows the risk-adjusted benchmark that we set by looking at top performers. So for heart failure and shock, top performers do better. They have a lower percentage of patients with heart failure, and their per beneficiary per month spend is lower. This tells us that the KCE should work on addressing heart failure exacerbations within their population. Interestingly, I'll also point out that vascular procedures, if you look at the ESRD row under vascular procedures, there's quite a bit of spend there, about $1.1 million. But we can see here that the KCE's risk-adjusted performance is actually lower than the top-performing benchmark. The red line is close to and a little to the left of the green line. So this KCE is one of the top performers on this particular category. So what this tells us is that it's likely going to be hard to drive spending even further down within the vascular procedures category, and it probably shouldn't be an area of focus for the KCE. The focus should really just be on maintaining their current performance in this category. So I hope that was a helpful example of identifying savings opportunity. There's one more topic within sort of our leveraging data section that I want to cover, and that's preparing for changes to beneficiary alignment. So as you may know, beneficiaries are prospectively aligned to a KCE prior to the performance year. During the performance year, those beneficiaries could be de-aligned, and some new ones might be newly aligned. The change in that alignment volume over the course of the year is going to have important implications for the capitated payments you receive, as well as who's going to be included in the reconciliation to determine shared savings and shared losses. If they're de-aligned, they won't be included. So to orient you to the table on this slide, the first two columns show beneficiary alignment during a baseline period. There were almost 1,300 CKD beneficiaries and about 1,000 ESRD beneficiaries before the performance year started at initial alignment. For those of you that applied to the program, you're going to be receiving your initial performance year one alignment very, very soon in the next couple days or weeks. The columns to the right of this table show the benefit where the beneficiary ended up during the proxy performance year. You can see that of the 1,300 aligned CKD beneficiaries, 64% stayed in that category, but 14% progressed to end-stage renal disease during the performance year. They stayed aligned, but they progressed. And then 2 patients received a kidney transplant. What I want to draw your attention to is that there were 23% of beneficiaries that were initially aligned at the start of the performance year, but were de-aligned during the performance year. Now, de-alignment can occur if a beneficiary is not receiving ongoing care from you, if they're not receiving their MCPs on a monthly basis or the QCPs on a quarterly basis for CKD. These patients that get de-aligned will not be included in reconciliation, as I mentioned. And when at the time of de-alignment, you're going to stop receiving those capitated payments. So this is a pretty significant example of de-alignment. But when we look at different practices across the country, it's not uncommon to see about 10% de-alignment over the course of a year. So and then the other thing I'll mention is we do notice a disproportionate amount of newly aligned CKD 4 and 5 patients that get aligned to you during the year. Those get de-aligned, they sort of flip over at a much higher rate. And since this program prioritizes or incentivizes keeping patients in CKD stage 4 or 5, I would suggest focusing on getting those new patients in for regular visits to keep them aligned so that you can get credit for caring for them and managing their disease. So the bottom line here is that alignment patterns are going to vary by practice, but as you're going into this model, you should really know what to expect specifically for your organization from an alignment perspective. Okay, so now that we've talked about ways to use your data to set yourself up for success in the model, we're going to switch gears a little bit. There's some great potential upside in the program that we just sort of touched on, but there's also pretty meaningful downside risk. And I'm going to turn things over to my colleague, Keely McMillan, to discuss some options for protecting that downside.
Great. Thanks, Sam. And thank you, everyone, for joining us today. Sam mentioned there is meaningful downside in this program. And next, we're going to walk through some important considerations for protecting that downside in the CKCC model. Before we do that, we just wanted to ask one more poll question. So can we have the last poll question, please, pulled up? So this question is, which statement most closely aligns with your organization's tolerance of risk? So which statement most closely aligns with your organization's tolerance of risk? So questions starting to come in here. Great. So questions still, responses still coming in here, but it looks like roughly a quarter of folks are prepared to manage the downside risk of this program in-house. And that does make sense given we saw roughly 50% of folks participating today participated in the ESCO model. It also looks like about 20% would prefer to offload the risk onto a third party, and then about over 40% don't know. So hopefully we can be helpful here as we help you think through that decision. Okay. So as Sam discussed earlier, the graduated level 2 professional and global tracks have meaningful downside risk. These would not be considered advanced alternative payment models if they didn't have real risk. And we'd like to spend a few minutes talking about ways in which you can mitigate that risk and some of the things to be thinking about as you evaluate your options for protecting your downside in this program. And just one quick note on the poll question. It's been our experience from working with specialty provider groups and a whole host of Medicare models that a routine approach to protecting your downside is to offload it onto a convener or a GPO or an LDO. And in doing that, you give up a big chunk of your upside and sometimes your autonomy, and you might receive varying levels of tools and support. And it's also been our experience that in giving another organization all of your downside and all of your upside, you no longer really have skin in the game, and the program is no longer a top priority, and you just don't achieve the success you really could have. And this approach might very well be the right fit for some groups. But for providers who are ready and have the ability to be innovative and maximize their upside, you don't need to sacrifice your upside to protect your downside. And along those lines, what we want to talk about today are two novel risk protection options that weren't available to participants in the ESCO model. And those are, one, the ability to purchase beneficiary specific or spec coverage from CMS, and that comes with 3 attachment points. Attachment points being spending thresholds above which CMS takes most of the risk. And there's also the option to purchase aggregate insurance or AG insurance, which is a policy for your aligned patient population as a whole. And that can be purchased from the commercial market, and that's tailored for your practice and for your performance. So let's look at these options in a little more detail. First, let's look at the option to purchase beneficiary specific or spec coverage from CMS. This is an option that CMMI has started offering in some of the newer models. It's an option in the next generation ACO model. It's an option in the new direct contracting model, and then we see it here in CKCC. And in this optional arrangement, CMS sets attachment points, again, which are spending thresholds for individual high-cost outliers. And once these spending thresholds for an individual are hit, CMS takes on more and more of the risk. Or said another way, more and more of that spending above those thresholds is excluded when CMS goes and adds up your spending for the performance period. Now, KCEs that do opt into this arrangement will be charged for it. Now, instead of paying a premium the way you would a typical insurance policy, CMS is going to add the cost of that premium to your performance year expenditures. So your expenditures will be higher than they would have been if you didn't opt into this arrangement. And by adding the charge for the spec stop loss to your performance year expenditures, that charge is effectively coming out of your shared savings. Or in the event there are losses, it's increasing your losses at reconciliation. Now, the charge that a KCE pays is specific to the KCE, and it's based on the KCE's own percentage of expenditures above the attachment points during the baseline period. So in other words, the charge is equal to what the payout rate would have been historically in the baseline period. So if you had a lot of high-cost outliers during the baseline period, your charge will be higher. If you had very little high-cost outliers during the baseline period, your charge will be lower. The attachment points themselves are calculated prospectively and are based on a national reference population. So in summary, the amount CMS charges you is based on how much of your organization's spending came in over the attachment point during the baseline period. In other words, your historical payout rate. And that amount is risk adjusted and is also adjusted for geographical payment factors. So let's look a little more closely at how these attachment points work. For KCEs that opt into the CMS spec stop loss arrangement, for every beneficiary, there will be an attachment point or dollar threshold above which CMS takes on a majority of the spending. Anything below the first attachment point is fully attributed to the KCE. All of that spending counts when it comes to adding up your performance year expenditures. Now, after you hit the first attachment point, so after an individual beneficiary expenditures hits that first attachment point, a majority of the spending above that does not accrue to the KCE. In other words, a majority of the spending will not count to your performance year expenditures. More specifically, for spending above the first attachment point and below the second attachment point, 70% of the spending is excluded from performance year expenditures. Now, spending above the second attachment point and below the third attachment point, 80% of that spending is excluded from performance year expenditures. And then above the third attachment point, 90% of spending for that high cost individual is excluded. So you're still paying 10% co-insurance on the highest cost outliers. We are still waiting on some more detail from CMS, but they did say they will be calculating a beneficiary level attachment point that is at the 99th percentile of spending. And that will be done separately for the CKD population and the ESRD population. The 99th percentile for ESRD patients is roughly 25,000 PMPM, which for the year is in the ballpark of $300,000. This will be based on the national reference data that CMS pulls, but you get a sense of how high these attachment points are. So, should you elect to opt in to the CMS spec stop loss coverage? There isn't a one size fits all answer here. So here are some of the things to be considering to make sure that you're making the right decision for your practice and your patient population. A benefit of the spec stop loss that's offered by CMS is that you don't have to pay the premium upfront in cash. Rather, CMS is going to take that charge out of your shared savings at the back end. Or in the event there are losses, CMS will increase your losses on the back end at the time of reconciliation. Now, to be clear, you're also not receiving payouts from CMS as high cost outliers occur. CKCC is not a full capitation model, and so therefore there's no need for you to be receiving payouts as high cost outliers occur. CMS will quote unquote pay out stop loss protection at the time of reconciliation, and that they will be factoring that into your shared savings or your shared loss calculation. Some other things to keep in mind, the attachment points are based on a national reference population, and given the nuances of your unique patient population, those attachment points could be favorable or they could be unfavorable. Additionally, because the charges for the premium for spec stop loss are based on your historical beneficiary population, to the extent your beneficiary population changes over time, that could mean your charges are underpriced or overpriced. As Sam showed us earlier, you can have a fair amount of de-alignment and or newly aligned beneficiaries for a whole host of reasons. And that does have implications for the value of the spec stop loss coverage. Now, if you were to have no changes in beneficiary expenditures or risk scores between the baseline period and the performance year, then the spec stop loss charge and the payout would be equal. It'd be a wash. There'd be no benefit. But to the extent there are changes in your beneficiary expenditures and risk scores, which of course there will be, the spec option could be favorable or it could be unfavorable. And in fact, in the example that CMS uses in its document called Financial Operating Guide for Payment Mechanisms, the KCE in this example spends more on the charge for the stop loss protection than the payout it receives. So in CMS's example, the KCE would have been better off not purchasing spec stop loss. It's also important to note that spec does not help when you really need it the most. In other words, it doesn't help when spending at the population level comes in way over benchmark. The spec thresholds are very high, 99th percentile. And sometimes what we see is an organization has a bunch of high-cost patients with spending that comes in below the attachment point. So that risk-bearing organization is not getting any protection despite a large amount of excess spending that is accruing. And in fact, in a simulation study conducted by Archway's actuarial team, specific stop loss is not particularly well aligned with a population-based model like CKCC, in that most of the time it either underpays for losses or it overcharges in premium. It could underpay for losses if, say, you have a lot of high-cost patients that weren't costly enough to trigger outlier protection. So in total, you're coming in way over benchmark without any stop-loss protection. Or it could overcharge in premium, and then it pays out even when you're generating savings in the model. So you're effectively paying for something that you didn't really need. An aggregate product, on the other hand, which has an attachment point for your whole patient population in aggregate, offers more protection than spec and has a premium that can be priced more competitively than a spec policy. So you're getting more protection for your premium dollar, which makes it a more efficient way to protect risk in these types of models. Now, in an ag product, you're still getting protection from those catastrophic cases because the spending from those catastrophic cases is still counting toward your aggregate attachment point. It's just less likely that you're paying for something you don't need. And in this next slide, we can see a visualization of the simulation study conducted by our actuarial team that's designed to illustrate how a spec policy works in a program like CKCC versus an ag policy. With the spec stop loss simulation shown on the left, and then the aggregate stop loss simulation shown on the right, each of the dots you see represents a simulated KCE. The x-axis is showing how much is paid out in stop-loss protection minus the cost of the premium. So basically, the x-axis is showing what a KCE is getting from their stop-loss policy. The y-axis is showing the KCE's shared savings or shared losses. And you can see that break-even line going across the middle with 0 gains or 0 losses. And then shared savings are below the line and shared losses are above the line. So each of these dots represents a simulated KCE with shared savings or shared losses and what the KCE is getting from its stop loss policy with those shared savings or shared losses. And what's clear is the aggregate stop loss, shown on the right, is a more targeted way to limit exposure. Both insurance structures have some correlation between losses and stop loss payout, but the aggregate product on the right is much more targeted, and there aren't payouts when there are gains, and it is more fully aligned with shared savings. The dots that are colored in green are better off with ag policy. Aggregate stop loss is more favorable for the green colored KCEs. And that factors in the amount that you're paying in premium. And then the dots that are colored in red are better off with a spec policy. And so we see in this simulation study that over 60% of the time, the KCE is better off with an aggregate policy. And what's also clear from this visualization is that aggregate stop loss provides more protection for extreme losses. So for those dots way up at the top, in extreme losses, ag works better, and that's when you need it the most. And for a CFO who wants assurance that the organization will never lose more than a certain amount, an aggregate product is the only product that can do that for you and might be the better fit. So these are some of the things to be thinking about when it comes to thinking about risk in CKCC. Let me hand it back to Sam now to talk about some of the other strategic considerations for participation.
Thanks very much, Keely. So we've talked about leveraging data to try and set yourself up to be successful, and we've talked about protecting your downside risk. There are just a couple of additional considerations we'd like to cover briefly. And this first topic, we built these slides without knowing the full sort of audience we have, and it looks like the vast majority of our webinar participants are planning on participating this year, which is fantastic. We're thrilled to see that. But we did just want to highlight a couple points because there are some people that haven't applied or haven't considered applying to this program yet. And for those of you, we think you should consider applying in cohort 2. First of all, CMMI has provided significantly more detail about the program. If you were looking at it last year, you might have had reservations about the model or didn't feel ready or didn't know enough about it. And a lot more information has come to light, which is helpful in preparing. Medicare has also shown that they can be really responsive to stakeholder feedback. This is something we see in almost every Medicare VBC model. If stakeholders and advocacy groups make a well-supported point as to why something should be different, Medicare listens and can respond. So a couple of examples are the adjusted monthly capitated payment wasn't going to work, and so Medicare revised it to be better for nephrologists. Another example is the financial guarantee. As part of CKCC, KCEs have to put up a financial guarantee in the form of funds in escrow or a line of credit or a surety bond. And the initial proposed amount was too high. And so Medicare more than cut it in half. They reduced it significantly. So that financial guarantee is much lower. I will say one more time, because I haven't said it enough, that this is a valuable opportunity to get experience in value-based care models. VBC is coming. We encourage everyone to learn about it and get practice now before it gets even harder. And as I mentioned, get your data. And then the last point I want to make on this topic is about the pandemic that we find ourselves still sort of struggling through. Cohort 1 applications were due before the pandemic really became an issue. But one of the things that we've learned over the past year is that providers in value-based care models fared better throughout COVID. Not only were the reliable prospective payments an important source of revenue for providers, but we also have seen that VBC organizations have the infrastructure in place to better care for patients when our delivery system sort of gets turned upside down. So sort of some unexpected silver linings, I guess, of the pandemic and these models. Another consideration that we want to cover briefly is evaluating your options to achieve sufficient volume. So, as you may know, in order to participate in CKCC, your entity has to meet certain volume requirements. You need 750 aligned CKD patients and 350 ESRD beneficiaries. We know that not every nephrology practice can meet that minimum on their own, and there are several options for achieving that sufficient volume. You might partner up with another practice or two in your region to create a new KCE. Your KCE could aggregate with another KCE. Aggregation is sort of a specific opportunity that Medicare allows within this model for low volume, non-LDO KCEs. There are some specific requirements about aggregating. So, we can provide more details after this webinar if that's something you need to learn more about. The deadline for cohort 1 to aggregate is the end of this month. And then the third option to achieve sufficient volume is what Keely was talking about a little bit, and that's joining a convener type entity or an LDO run KCE. They can certainly help you meet volume requirements. Regardless of those options that I just ran through, evaluating your potential partners is super important since it's going to have implications for your performance in the program. If you are well positioned to earn savings in the program, but your partner, another practice on your KCE or an aggregation partner, is a poor performer, their losses will reduce your upside. Reconciliation happens in total. So their downside is going to cut into your upside. And if that's, you want to be aware of that. So the data insights that we reviewed earlier today can be leveraged beyond just looking at your own organization. You can use these types of data insights to identify ideal partners that you would want to work with to meet those volume requirements. So you might want to try and find an organization that has a similar focus area for savings or something along those lines. So those were just a couple of additional considerations. I want to save some time for questions, so I'm just going to sort of do a really quick teaser here. Kidney transplants are a very important piece of the KCC program. We didn't really cover it today. This dashboard is a taste of what we hope to cover in a future webinar. But what this dashboard is showing you is that we can leverage data to learn a lot, right? We can estimate what that kidney transplant bonus is going to be since it's paid out over time, help you understand sort of the funds flow there. We can use peer comparisons to see how your practice's transplant rates might stack up to other practices. And then we can evaluate individual physicians and look for variation among referring nephrologists or transplant surgeons to identify top performers, to identify where there's opportunity for improvement. So again, kidney transplants, we're just touching on it so briefly here, but it's an important topic. So stay tuned for more information on this. And with that, I want to thank everyone for attending today's webinar. For those of you that are getting ready to start this program in March, we wish you the best of luck and are here to help if you have any questions. Before we get started on the Q&A portion, I do want to let you know that you can reach out to us at any time if you think of questions later, or if you're interested in receiving a complimentary KCC scorecard. So we have an example scorecard here on the right. This is something that we could put together for you for free to help you understand at a very high level what your risk and upside potential might be in the program. And if that's something you're interested in, you can contact us at info@archwayha.com. So we have just a couple minutes for questions. Please, we've had some come in. If you have more, please submit them using the question mark icon at the top of your webinar platform. Keely and I are going to pause for just a couple moments to sort of compose these questions, and then we'll start answering. So bear with us for just a moment.
Great. Thanks very much, Sam. And thank you, everyone, for submitting questions. It's really helpful. A couple questions that have come in. Can participants get spec insurance in the commercial market, or do you have to buy from CMS? Well, first, just as a reminder, it's totally optional to opt into the spec from CMS. There may be spec on the commercial market, but as a reminder here, it doesn't make sense to purchase traditional commercial spec because KCEs you're still paid fee for service in this program. You're still billing and getting paid fee for service, Part A, Part B in this model. It's not a fully capitated model. And so the benefit of traditional spec is when you're in a capitated model and there's a high cost claim, you get paid by the spec payout, and that helps you with cash flow. But in a fee for service model, there's no need for that. Another question that came in, is there going to be a new cohort in 2023? Medicare hasn't indicated any plans to have a second phase of this. In many ways, as Sam talked about earlier, this program is the next generation version of the original ESCO model. I think by the time we get around to 2023, CMMI has indicated that based on what they find is working or not working in these pilot models, they'll make that mandatory. And I think ETC is an example of that.
Thanks, Keely. I have a question I'll answer now because it's a good one. How does CMS adjust for COVID in CKCC? So that's an interesting question for those of you following value-based care programs over the past year. Medicare has offered several flexibilities for participants to waive downside risk amidst the public health emergency. CKCC is a little different in that it's starting over a year into the pandemic. So as I mentioned, the program has already been delayed by a quarter. And, qualifying QCP codes have been expanded over the past year or so to include telehealth. So that's sort of in response to CKCC, in response to the pandemic. But there are no specific plans to offer sweeping protections if the pandemic continues. The good news is that the baseline period for CKCC is set from 2017 to 2019, and it's not going to roll forward. It'll just be trended forward. So the crazy year of wacky utilization that was 2020 isn't going to interfere with the benchmark. And lastly, I'll just mention that Medicare has told us that they are considering the impacts of COVID on risk adjustment and have advised us to sort of stay tuned there. So that's something that we're going to continue to track. We are bumping up right at 3:00. We have several more questions that we haven't had a chance to get to, but we do want to be respectful of everyone's time. So for those that have submitted a question, we will try our best to follow up. If not, feel free to contact info@archwayha.com. And this marks the end of the webinar. We will send a recording to those that have registered. And thank you very much again, and have a great afternoon.